Hello and welcome to another episode of the GenerEhlist podcast, CFPC 105 Topics Podcast. Today's topic is renal failure.
It was written by Vaishvi Patel, a third-year med student from the University of Alberta, who you heard before, and who you just heard now, Ronan Noble, MD PhD student from UofA, also. Reviewed by Dr. Whitney Hung, internal med senior resident in Edmonton, Alberta. Thank you, Dr. Hung.
Thanks, Dr. Hung.
So should we get going on these objectives?
Yeah, absolutely.
Objective 1. In patients with chronic renal failure, ensure they're aware of their diagnosis and its implications.
Right. So to no one's surprise, as soon as chronic renal failure is diagnosed, patients should be made aware of their diagnosis. It's helpful to define chronic renal failure, of course, in layman's terms. For example, presence of kidney damage or decreased kidney function for 3 or more months.
Yeah. And tell people about what these stages are. They'll likely need to have already been primed, as the investigations are monitoring to reach this diagnosis will have already taken place. So tell people what's going on.
They should be reminded that further testing may be required to better work up their renal failure or monitor kidney function. This would include blood tests and imaging.
And they should also be made aware of the variety of symptoms associated with the renal failure. These might be things that actually seem asymptomatic, like changes in appetite, urinary frequency, fatigue, muscle cramps, edema, chest pain, shortness of breath. It's not just the kidneys.
And of course, some of these symptoms may be associated with the progression of disease. So even if they are not experiencing them now, unfortunately, they may come later and could be a sign of other comorbidities which are precipitated by renal failure.
Moving on to Objective 2. In any patient, mitigate the risks of precipitating renal failure when investigation and treatment combinations could be harmful.
So I guess this one kind of speaks for itself. There are several treatments and investigations which need to be watched closely in patients with chronic kidney disease.
While we're not saying all of these need to be avoided, you need to take care that we don't overly stress the already compromised kidneys and cause AKIs, accelerated kidney function loss, or other consequences like electrolyte disturbances and bleeds.
Things which precipitate renal failure include contrast dye, bowel preparation, and a number of medications. Can we go through those one by one?
We can. The contrast dye will always come up and it'll always be on your exam, but it is my opinion, and I will die on this molehill, that is bullshit. But carry on.
General recommendations are to maintain euvolemia before and after receiving contrast.
Easy peasy. That's straightforward enough. For bowel prep, anything containing phosphate, which is actually used to draw water into the bowel, could increase the risk of phosphate nephropathy, as well as other electrolyte disturbances. That's the big ones there. Should we talk about meds?
Absolutely. Thiazide and loop diuretics are commonly used for blood pressure control in patients with reduced GFR. This is critical in advanced chronic kidney disease where blood pressure becomes more sensitive and excess volume becomes a concern.
And of course, overdoing it with the diuretics because you just want all that edema to go away can increase the risk of an acute kidney injury, particularly in patients who are edematous or those who are already volume depleted and you just don't know it.
Right, but of course it probably goes without saying that thiazide and loop diuretics are often used for long-term management of your chronic kidney disease. Thiazides in particular are a recommended add-on therapy for hypertension management after ACE inhibitors for this population, and most patients need loop diuretics for their edema management.
Just remember, these are sick day meds. They may need to be held during acute illness, but they shouldn't necessarily always be avoided. You just have to be careful.
Right, and then I guess we should say RAS blockers also deserve some attention as they are essential to chronic kidney disease, but also have the potential to cause harm. So kidney disease as well as hypotension from RAS blockers is particularly at risk in patients who have congestive heart failure, active diuresis, or other illnesses which would cause a volume depletion.
And then if you're putting on more than one RAS blocker, or when the RAS blockers are combined with others like ACE inhibitors, NSAIDs, SGLT2 inhibitors, then the risk of kidney injury can be amplified.
And we need to keep in mind that when we start an SGLT2 inhibitor in particular, GFR can transiently decrease. Of course, SGLT2 inhibitors are renoprotective, great for the kidneys, but
apparently they're good for everything. We use it for the heart, for kidneys, for diabetes. It's crazy, man.
They're magic.
Absolutely.
Real quick, other medications to keep an eye on in chronic kidney disease include metformin, aminoglycosides, digoxin, lithium, phenytoin. Why don't you finish it off for me, Caleb?
Tacrolimus, warfarin, piperidine, and morphine. Basically anything which is nephrotoxic or eliminated by the kidneys or could build up with kidney injury needs to be monitored and avoided if possible.
Okay, enough about drugs.
That was a ton. Can we move on to something else? You bet we can.
Yes, please.
We control our destiny. Objective 3. When prescribing drugs to a patient in renal failure, determine drug safety, adjust doses when appropriate, and monitor the impact of the drug on renal function.
Right, so a framework to this medication assessment was wonderfully described by Whitaker et al., which we've linked in the show notes. First, check your patient's renal function. We need to know the most recent GFR to determine drug dosing.
Next, collect a complete med list. This is going to include all prescriptions, over-the-counter meds, and any other dietary supplementations. That's the secret. Ask them about the weirdo dietary pocket from the lady down the street they've been taking.
And then review those medications. Questions to involve include, is this medication nephrotoxic or contraindicated in chronic kidney disease at a particular GFR? How does this drug or drug metabolite half-life change in chronic kidney disease? And of course, does chronic kidney disease increase adverse drug-to-drug interactions in this medication?
That sounds way too smart for me. I hope we're working in a practice with pharmacists. And finally, does this drug have a narrow therapeutic index in CKD that needs more intense monitoring?
And then, of course, we want to adjust said dose based on that GFR. Also, it makes sense to consider deprescribing medications when their benefit may now outweigh the potential effects that are exacerbated by your chronic kidney disease.
And finally, in this section, monitor the impact of the drug on your patient's renal function. Focus on efficacy, toxicity, and kidney function.
Makes sense to me.
So what did we do here? We collected all their meds together so we know everything that they're taking, including non-prescribed stuff. We reviewed each to see its effects on the kidney and if it needed to be adjusted for GFR, more intense monitoring if it had a narrow index, and deprescribing where we need to. Nailed it.
Easy peasy.
Objective 4. Advise patients with existing moderate or severe renal failure to pay close attention to hydration.
So hydration is challenging, but of course important for patients with renal failure, as well as really everyone. A normal thirst-guided intake should determine patients' water intake unless there is a specific reason to increase fluid intake, such as salt-wasting nephropathy, central and nephrogenic diabetes insipidus, or preventing urolithiasis.
However, patients with chronic renal failure are often told to follow a salt-restricted diet to avoid holding on to excess fluids. Sounds simple enough, yeah?
Yeah, absolutely. Unfortunately, it's very easy for patients to get dehydrated, especially when patients are traveling, ill, exercising, or even just experiencing hot weather. And any of these could, of course, result in acute or chronic renal damage.
Therefore, patients should be told to pay close attention to their hydration status by monitoring their fluid intake, as well as their urine color and urine volume. Which brings us back to the topic of drugs. Objective 5. Advise patients with existing renal failure to avoid certain over-the-counter treatments.
Right, so this will include your classic NSAIDs, which impair renal autoregulation by inhibiting prostaglandin-mediated vasodilation.
And then there's a bunch of natural compounds they should probably dodge as well, such as noni juice, the ever-scary St. John's wort, ginkgo biloba, ephedra alkaloids, and, with deep sadness, especially for our northern Scandinavian colleagues, licorice.
Not licorice. Take anything but the licorice. Also, we have some kidney-safe candies below in the show notes, just in case.
Nice.
Okay, on to Objective 6.
Objective 6. In patients with moderate or severe renal failure, provide anticipatory guidance that if they become ill and they can't maintain fluid intake, they should stop certain meds and seek prompt assessment.
As we've previously mentioned, staying hydrated is very important for our patients with chronic kidney disease. Patients with moderate or severe renal failure should be provided with anticipatory guidance before they become ill and struggle to maintain fluid intake.
And then generally when that CKD patient struggles to have enough water, they should know which meds they should stop taking and seek prompt reassessment so the physician can review the meds and limit their risk of causing an AKI. So, how do I know which meds to tell my patient to hold?
Oh, I'm glad you asked. That's your classic sad man's mnemonic. S is for sulfonylureas and other secretagogues.
A is for ACE inhibitors.
D is for diuretics and direct renin inhibitors.
M is for metformin.
A is for angiotensin receptor blockers.
And the N is for NSAIDs, which we talked before.
And of course, S is for your SGL2 inhibitors.
All right, that's fine. But let's say our patient doesn't monitor their hydration status, which most of them won't, and they exacerbate their renal failure. Now what do? It's too late.
I think we have an objective for that, so we'll be okay.
Objective 7. In a patient with an exacerbation of their renal failure, you should correct factors, stop drugs that might be aggravating the situation, and determine the appropriateness of restarting meds once renal function's stabilized.
Sounds easy enough. So this objective provides a pretty good framework for how to deal with acute or chronic renal injury alone.
I'd say we should break this up in the classic way: pre-renal, renal, post-renal. What do you say?
That sounds good to me. So what would that look like? What's pre-renal, for example?
Pre-renal's before the kidneys, so it's usually impaired perfusion from things like dehydration, blood loss, infection, vascular occlusion, congestive heart failure, all these not kidney things that might be causing kidney problems. The renal causes are things within the kidneys, so things like AIN or acute interstitial nephritis, ATN, acute tubular necrosis, which can happen when you're too dry for too long, glomerulonephritis, so if you see some blood in the urine associated with it, that might be a trigger.
Right, and then finally we have postrenal, which is usually due to an obstruction from prostatic hyperplasia, urinary calculi, strictures or tumors, anything kind of obstructing your flow below the stream.
And if the clinical picture and cause isn't clear based on history and presentation, you'll just have to get more investigations to get that data. But in the meantime, we're going to follow our sad man's drugs that could aggravate things, especially if we think dehydration might be contributing. And then what?
Well, hopefully you would identify the cause of the exacerbation and begin to treat said cause.
So if they're dehydrated, we should hydrate?
Maybe hydrate. That's a good start. What if there's an infection? What do you do for an infection?
I guess we could treat it too. Give some antibiotics.
Yep. Okay. And then post-renal, maybe we treat the cause again.
Yeah, might be removing a kidney stone, which I'm not going to do, but one of our awesome uro colleagues are. Same with dilating strictures or removing tumors. That would be their jam. If I can just put in a urinary catheter, that might be helpful too.
Great. And then if it's decompensated heart failure, another classic cause, I'm guessing we would first...
Go look at the heart failure episode.
It was a good one.
Oh, is it? Awesome.
Yeah, I liked it.
Yes, go see the heart failure episode, but you get the point. Reverse the thing that's causing the kidney failure.
Sounds good. I guess we can move on to Objective 8 then.
Objective 8. Monitor patients with renal failure periodically, as some will worsen over time.
And this is the unfortunate but harsh truth of kidney disease. General management consists of treating reversible causes of renal failure, slowing its progression, treating complications, identifying and preventing comorbidities, as well as adjusting drug doses.
And there's tons of moving parts that need to be monitored, so good follow-up with primary care physician is key in managing patients with chronic renal failure. This could be every 3 to 6 months.
That makes sense, and I think our next objective builds off this a little bit, which is...
Objective 9. For patients with renal failure, determine, based on patient factors and local resources, if and when consultation is needed.
The guidelines are quite clear here. Patients should be referred to nephrologists for the following reasons: a GFR of less than 30, or
unexplained progressive decline in GFR more than 5 mils per minute that occurs over 6 months. Besides these two, some other reasons for referral include
persistent albuminuria,
sustained hematuria not explained by a urinary tract source,
acute nephrotic syndrome,
suspected vasculitis,
glomerulonephritis, and a persistent albuminuria.
or even resistant or suspected secondary hypertension in the context of CKD,
Persistent electrolyte abnormalities,
hereditary kidney disease.
or recurrent or extensive nephrolithiasis.
So these are kind of the ones that you just send a note to their clinic and hope that they see them in the next weeks or months. What are some reasons for an emergent referral?
Right, so this would be a new diagnosis with a GFR of less than 10, life-threatening uremic symptoms such as hyperkalemia, pulmonary edema combined with kidney failure, pericarditis combined with kidney failure, or even rapidly progressive kidney failure with a significant decline in kidney function over the days to weeks.
And keep in mind for the exam, they're not looking for provincial standards. They're looking, if there's a national standard, that's what they're going to want. And we've provided a quick provincial referral guide in the show notes as well. KDIGO international guidelines are also generally followed for management, so those could be an additional resource, once again, in the show notes. KDIGO, somebody's going to grill you on an internal medicine block on these. Is this technically an AKI? What are the threshold values? Final objective. Ensure those involved in consultant care of patients with renal failure are aware of other important health considerations that might affect decision-making around your patient's treatment. So studies have shown associations between early involvement of nephrology and both improved morbidity and mortality, as well as an overall decrease in healthcare costs. Therefore, it's critical to get nephrology involved when appropriate. Did I tell you the nephrologist told me I was trying to fix someone's kidneys? I forget what was wrong with them. And they said, there's no physician alive who's smarter than the dumbest kidney. And that's coming from the kidney people, so. Getting these people involved really makes sense. Kidney people are good with kidneys. Where does primary care come into this? In order for nephrology to make the best treatment decisions, they also need to be aware of all possible health considerations, which would be known by their primary care physician who has been following their patient for presumably a very long time. This would include other medical conditions, risk factors, patient preference, and other patient factors such as cognitive status, socioeconomic background, location, history of substance abuse, family dynamics. I'm sure the list goes on and on from there. And considering these factors is also going to help determine if other consultants or health professionals are going to need to be involved in your patient's care. All right, that's it. Easy peasy. That is renal failure from the CCFP 105 Topics podcast. Thank you to both Vaishvi and Ronan for writing the episode, and thank you so much to Dr. Hung for reviewing it. You are a wonder. Thank you for tuning in, and as ever, reach out with any feedback if you want to get involved with this project. Yeah, send us a message. Okay, bye. Take care.